right, hi. This is Eric Wilkie, Joel Betts, and we've got Fred Lemaire, all the way from near Montreal in Canada, creator of the Easy Resus app. And so we were excited to have you on and would love to hear. So, first, like, how'd you get into medicine, and then what got you into emergency medicine specifically?
Hi guys, thank you so much for having me. It's an honor to be here with you. It's really crazy because I was not in the career path of being a doctor at all. When I was, do you remember the movie Apollo 13?
Oh,
I
yeah.
was about 11 years old when that movie came out. And there's this epic scene where they are three squeezed in the lunar module and the CO2 level kept rising, and then
Yeah.
they kind of saturated the CO2 cartridge, and they talk back, and this is like a real life story to the aerospace engineer on Earth. And there's this scene where this guy is like, guys, you need to fit like this round pack in a square hole with this equipment, and you've got like an hour before they die. And after this movie, I was like, I want to be that guy. I want to be the kind of guy that someone is dying, there's a big problem, and you need to solve it like in 1 hour with duct tape. And I was sure I was going to be an aerospace engineer. There's even like a news article when I was like in primary school of me talking to the journalist that I was going to university to be an aerospace engineer. And when I actually started high school, I kind of slowly realized that aerospace engineer, they don't really save lives with duct tape. They kind of just do mathematical equation and complex like optimization of space rocket engines. And then I kind of redirected like slowly to medicine. And when you think about it, like emergency medicine, there's a lot of that. Like someone is dying, you need to figure out the problem very quickly. There's a life at stake. Sometimes there's duct tape involved, but it's really rare. But we've seen occasion in remote places.
A lot
So
of
I think
stuff
it's
like duct tape. Yeah,
Yeah.
exactly.
exactly, but like the challenge of having like the life of another human being at stake, like this is like big responsibility, and you need to take care of it very fast. I think it was part of why I kind of pivoted from aerospace engineering as a young boy to finally become an emergency doc.
So when Apollo 13 came out, my brother was in college and doing an internship with NASA. Was actually at the Johnson Space Center writing code for the space station life support systems. And so all the engineers went to go see Apollo 13, and they had rented the whole movie theater, and they were all cheering because like the nerds rule, right? They saved the day.
Exactly.
And,
They finally vindicated. Yeah,
yeah.
exactly.
Yeah. And you know what is really crazy when you think about it is that like there is audio transcript of this whole procedure, but it was only audio. So they were like, so you take the plastic sheet and bend it and take like this inches of duct tape and put it on the posterior aspect. Like this is kind of crazy to kind of convey all this like in a rigging operation, but only talking to the astronauts. So I thought it was cool. And like the big rumor is that it was not exactly like in the movie, that there was like the lead engineer in his car, like having this problem and just kind of said, I bet we could do that. And it was really like a one guy idea in his car. So
Wow.
I think it's pretty awesome.
That's crazy.
Yeah. So, all right. So you get into emergency medicine because of Apollo 13, and then several years ago, like you started this Easy Resus app. So how long ago did that start, and what was the genesis? What was the trigger for this?
Oh, that was very, very tough. So it right now it's almost 10 years when it happens. I was a second year attending, and in your career as an emergency physician, at
Mhm.
first, like you're stressed out of your mind because this is too crazy to have all the responsibility. But then you go on a plateau where you're like, yeah, I can do this. I've run a couple of cardiac arrests. I intubated some patient. Maybe that's not that difficult. So I was at this point where I started to feel that I was good at it. And then, like, I still remember everything. It was an evening shift, pretty calm. And, like, I'm writing a patient note on the counter. And I heard Sebastian scream. Like, Seb is this veteran nurse. You've seen, like, nurses like that who've been doing this for 20 years.
Mm-hmm.
always joking. They've seen everything. They are always like calm and composed. So I was like, okay, so rule number one, if that guy is screaming, like this is a
Right.
catastrophe. Like catastrophe. Like he's always unfazed, on big trauma patient and all that. And I still remember just looking at him in the hallway. And you know how sometimes it takes kind of a second for your brain to register the whole picture. And I saw him running with a dying baby in his hands. And it was just screaming like code pink, code pink. And it was really tough because it was the first time in my career that I faced like total chaos. Because sometimes even on pediatric resuscitation, you get kind of a heads up. You've got like a call from the paramedic, and then you can assemble the team, you prepare the drugs, you prepare the equipment, you're like, okay guys, we can do this, we'll run this and that. But it was really just me in a recess room along with Seb and a dying baby, and total confusion. Like no parents, no story, no one to take charge of the airway, no vital sign, like total chaos. And we kind of screamed for help. We started resuscitating Benjamin, and it became clear in about 5 minutes that he was in profound septic shock, and we needed to do something about the blood pressure. And I just needed to start an epinephrine drip. And in my training, like it was the first time I had the pediatric resuscitation in my career. But past in like simulation I've done in my training, it was always kind of you say to the nurse, "Oh, start an epinephrine drip, zero point 0.1 micrograms per kg per minute." And then she said, "Yes, I'm doing this, doctor." And you're like, "Good." So we had close loop communication. Good job. But like first, I wasn't sure about the dose, so I opened up to date, and it was just all blurry. Like there was so much information on my phone. I was kind of scrolling and trying to go fast and just skipping past the information because it's really dense. It's not meant to be accessed when you're freaking out. It's meant to be accessed in front of a computer when you're calm and you can parse all this information. And then when I finally like had the dose, I just said to Seb, "Okay, so let's start the drip." And he looked at me like, "But what's the recipe?" Because the neonate was so small, like it was out of range for all the smart infusion pumps, and like it's pretty rare that you start an epinephrine drip and DED for a newborn. So the information about like how to mix it, do you put this in D5 in saline, is the concentration right, was not there. So we called the pharmacist, and like we're super lucky they came rushing downstairs, and they were literally like opening books and trying, and then you've been there, like the mother comes in, she's screaming, everyone is on edge. And when we finally kind of found the recipe, we've done the calculation by hand, and at the end I just showed my iPhone to Seb, and we didn't have the same result. And I completely freaked out because I was like, I'm the leader of this case, this kid is dying. You really feel viscerally that this is important because there's like 20 people, the mother is there, like I want to do everything to save this kid's life, and I'm the one about to do a 4-fold, 5-fold drug dosing error. So for me that was like a big take home. And finally like the kids end up super fine. Like we just say, "Oh, we've made an error," we kind of start the epi drip, we transfer him, and he was out of the ICU in like a week, no sequelae, no complication. But this case had a deep impact on the rest of my career as an emergency doc.
Hmm. Wow. I think we've got some of these cases. I remember it was a Christmas morning. I'm in the shower before going into shift, and I'm sitting here, washing our hair, and like, what's the worst thing I could see today? And I said,
Oh, I
well,
hate that game.
it would be a floppy baby, and like a brand newborn kind of thing, and that was my second patient, right?
Oh,
And and so it's like, is it congenital heart? Is it sepsis? What we're all, is it inborn error of metabolism? And you're kind of running through everything, and yeah, it's when you're maximally stressed, it's hard to think clearly, right? To try and calm yourself down so you can address the problem. So yeah, you're describing this case, and I'm getting a visceral response thinking back to,
yeah.
and since it was Christmas, and everything's booked,
Oh no.
the kangaroo crew from Texas Children's couldn't be there. It took him like 8 hours. So for about 8 hours, we got to be a pediatric ICU.
Oh
This
man.
is so tough. And you know what was my big take home about that was when you look at it, like the diagnosis part was not so tough. Like when I saw this kid, he was clearly dying. The blood pressure was low. He had a fever. It was like a grossly abnormal lung auscultation. The OSAT was low. So in like 5 minutes, I was like, this is a septic shock from probably a lung origin. And when you think at it like from a first principle thinking, this is not rocket science. Like you need to give oxygen and secure the airway, give a bit of fluid, broad spectrum antibiotics, maintain the blood pressure, and ship the baby out. But
Mhm.
the logistics of doing this as quickly as possible when the life of someone is at stakes and you're dealing with a lot of other professionals in the loop and that we can all screw up as human beings, then the challenge is enormous. And what I found really like surprising is that most of our training, we like to debate intellectual stuff. So we're like, oh, so I've seen this study that say that maybe there's a 1% better chance that there won't be low blood pressure if you use ketamine instead of this. And then, oh, but I don't like the way this study is structured. And then we kind of argue each other. But when you zoom out, the challenge is not that at all. Because even if you like select this 1% better drug, but after that, it's totally chaotic and you do like a 5 times drug dosing error and the tube size is not the right size to intubate the kid. Like this is killing people. And we don't, it's pretty rare that people say like, let's say like for a massive transfusion protocol, you remember like the proper trial where we were arguing about the ratio that would be used. But when I actually look at a massive transfusion protocol in real life, the problem is often the form that you need to fill, and then you call the guy, but he's out for lunch, and then there's a delay. So like we're talking about tiny difference from an intellectual standpoint, but the discussion should be we should have one guy that kind of go replace this guy who's at lunch so that we have the blood quicker. So it was kind of a big revelation early in my career that I needed to go all in on figuring out the logistics of resuscitations.
Mhm.
All right. So so after that case, and you now have the interest, like, all right, how do we attack this problem? Like, so where did that lead you?
Yeah, in fact, honestly, there was quite a long detour because at first, or for like back then, 10 years ago, I still had my iPhone 3. So the idea of doing a drug dosing app was not like no one of my friends were doing app. Like right now, it's not a big deal, but like 10 years ago, it was, whoa, do you know someone? This is kind of complicated stuff. So our big solution was like, we're going to do Excel table that will be so clear and full of information that we'll never have to like calculate anything for the rest of our lives. And then we spent a year, like a lot of friends, only volunteering with like respiratory therapists, some paramedics, nurses, pharmacists, all for the cause, you know? And we've done about like hundreds of those Excel tables. And at the end, we printed them in a booklet. And we were super excited about that. And we started like printing the booklet and giving it to everyone. And I paid like hundreds and hundreds of bucks just to have beautifully color print, and those were completely unusable. Like when I had there was like all those color charted, and then I had another case that was not as sick. I was just trying to flip like the booklet, and I was like, this is completely useless. And it's at that point that I realized that you've got two ways that you can deal with this. You either going to just do a small like card with limited amount of information, but that you'll be able to read when stressed out of your mind, but you won't get the entire data that you need. Or you put all the data that you need, but paper is not the way to access this information because the human brain is not able to go to a table of content to go at the right place when a kid is dying. So this is when we're like, okay, so let's do a drug dosing app.
Hmm.
And at that point, like it was not a business opportunity whatsoever. Like it was very naive in retrospect. It was just a bunch of, we just pour some personal money in, we hire a developer. And to give you an idea on how like unprepared we were, the day that the app was finished, I tried to publish it on the App Store, and I discovered that you need to have a company in order to publish like paid content on the App Store. So I was like, oh, so we'll create a company then. But it was not like a grand scheme of plan that, to build a business. It was just, let's do an app for ourselves and to solve this problem so that the next like kid that comes in, we are sure that we have the right recipe. So it's about in 2015 that we published Easy Drip, and it was like the first iteration of the app Easy Recess.
All right. So after you used it, you printed the paper ones, the nice, beautiful color Excel spreadsheets that were completely unusable, right? So now when you've got the app, using that in practice, what did you notice? Did it work pretty well? Did you have to make changes?
What was the most like weird thing that happened? You know how, like, let's say that globalization, okay, you don't really feel this on a visceral level. When you go to the grocery store, if you buy a banana, you just expect that bananas are there, but you don't really kind of feel that it comes from South America, that there is someone there with hundreds of employees with a very complex ecosystem that ultimately bring this to you. But when it's your product that you put out there, it's a very, very weird feeling, because at first we were doing this just for ourselves, but we were like, okay, let's like do an English translation and put this on the App Store. And this was like the first thing that was completely crazy. It's just that you go to sleep and you wake up the next morning, and the first email I got was from a pediatric ICU doc from Ohio. And it was like, I used your app on a dying patient yesterday, and you should put milrinone in there because like he was in profound cardiogenic shock. And it was like, oh my God, like I'm sleeping and this thing is helping like people in freaking Ohio. Like this is like very, very, very weird. And totally outside my comfort zone, because at first there was maybe, I don't know, like 40 drugs. It was working very well, but if you say, okay, Fred, let's put milrinone, like I have absolutely no like smart thing to say about milrinone for pediatric cardiogenic shock. I'm going to go on up to date like everyone else, and I can read it, but I have no personal experience. I wouldn't put extremely advanced tertiary care kind of content in my app. So it was like the first thing, like it works. It seemed like to be used outside like of what I was imagining was possible. And I need some kind of help to structure that, because there's no way I'm going to be helping pediatric ICU doc by being like a regular ED doc with no advanced pediatric expertise.
Wow. Okay. So what'd you do with milrinone?
Yeah, like there was a big one, because I have like even my friend who's working in a tertiary pediatric emergency center, and he has like this certification as a pediatric emergency doc. It was like, I've never used this, like remotely thought about using this like in my whole career. So we actually talked to a pharmacist, and he's a pharmacist working in a pediatric ICU in Quebec, in Saint Justine. And the guy has a fellowship in the pharmacology of pediatric ECMO. So I was like, oh, this is our guy. And when we talked to him, and we're like, should we put like milrinone? It was like, guys, milrinone is kind of the Tylenol of cardiac post-op. So yeah, you can put it like it's like day-to-day stuff for me. So I knew at that point that we had our guy to kind of take care of the crazy pediatric stuff. And from there, because it was still like not a business at all. Like we created a nonprofit organization. Everyone were volunteering their own time to put into this, and the team of volunteer over the years just grew to now 35 healthcare professional.
Yeah, I saw that on your website. I thought that was really cool that you have so many different, not just physicians, but nursing and EMS, and I just thought that was really cool, because we all practice in the same environment, but we really come from different training worlds, so that input is really critical, I think.
Oh yeah, you're so right. And especially when you're talking about the logistics of resuscitation, it's quite easy for the emergency doc, especially if you're working in a big center, to just say that things are out of your expertise, and you just kind of transfer the burden to another specialty. So like if you don't know how to mix a drug, well, it's the nurse's fault, and like I'm just going to do the prescription. But when you just focus on the patient and you say, we don't care about that, we just want to know how to mix this drug and administer it safely, then with the doctor alone, you don't have the expertise to create the easy drip or easy recess. You need the respiratory therapist to say, you know what, we usually say this in the textbook for tube sizing, but from my experience doing this for 20 years, I think we should err. Like, this is extremely valuable information, because as emergency doc, most of the time you just got ended, the stuff to intubate the kid, and someone else is doing all the calculation in their head. So to kind of put all those brain together is really the key way to make something useful.
Yeah.
Right. And so your Easy Drip was the first app, and then what? So when you moved from Easy Drip to Easy Resus, like, what did you add? What changed?
Yeah, because it's such a long story. But at first, like the nonprofit organization, we give our times for free and we give the app for free, was working. But we came to a point about 3 years ago where the scale of all that was becoming very, very, very tough to maintain. Everyone is super excited at first to do an app, but when you have about like 1,000 drug indication and you just need to maintain the scientific content, like, it's a lot of work. And then as soon as there's an iPhone platform, it kind of screw your whole app. So at first, in my mind, I was like, we'll do an app and it'll be okay for 10 years. And then like 6 months later, they switch from iPhone 3 to 4. And they're like, you've got 2 weeks and your app is not working, or we're going to kick you out from the App Store. So you're like, okay, so there's a lot of money to invest in that. So we started like selling the app to an institution. And at first it was helping us a bit, but then it became a lot of responsibility, because at first it's like a side project, but at that point it's still my phone number on the App Store if something is not working. So then I'm in the middle of a call of a shift, and I get call from customer like, I don't know how to reset my passwords. It's like the pressure was increasing, but the business model was not following along. So it became like just crazier and crazier, and at one point it became clear that we needed to do something else. And my vision was way wider than just the drug dosing. I wanted, like, ultimately to put everything in Easy Recess, like from a premature neonate to a super obese patient, to the equipment, to the drug dosing, to also all the condition, and ultimately all the emergency procedures. Because it's, at the end of the day, I feel it's always the same problem. Like, you train all your life to make a surgical airway, to make a crack. I've done one in my career, and the day that you're about to do it, you don't need like a 20-minute video. You're just freaking out because you want to be reassured that the tube size is right, and you just want to see the cut, just like 5 seconds to say, okay, oh yeah, I got this, and then you go do it. And we wanted to put all that into Easy Recess, but we didn't have any money to do that. But it's at this exact moment that we had the opportunity with the Canadian Space Agency to participate to the Deep Space Healthcare Challenge. So when I heard about the challenge, I was like, okay, so this is like a sign of the universe to go all in on Easy Recess and not just the drug dosing. So at that moment, I took a sabbatical to do the transition from Easy Drip to Easy Recess.
Wow. Well, I will say that I when we first reached out and I contacted you, I went immediately and downloaded the app, and within about an hour, I said, I'm just getting a year subscription of this, because the beauty of the app. So and I don't mean to. I mean, I think we all have like access to Pepid or Up to Date or whatever it is. But the problem there is you sign in and you're immediately overwhelmed with information, and you're scrolling and scrolling and scrolling. And you're like, where's the dose? And then they say, oh, this study says this dose and that study says this dose. But if you do this dose and you're in Iran, it might be a little bit, you're like,
exactly.
Give me the friggin' dose here. I need to, like, this kid is like, or this adult is crashing. I don't need 9 different options. What I need is, where do I start my drip? What size, equipment do I need? And so immediately when I saw that, I looked at the flow of that and I said, boom, this is worth its weight in gold. This is something that is going to be a standard, I think, in emergency medicine, not only for physicians and PAs, but all the way through nursing. I think this will be a huge, huge help.
Thank you
Well,
so much, Joel. It's exactly like you're putting into words what I was feeling during this kid's resus. It's like it's really tough when you never encounter resuscitation to understand the kind of pressure and burden we face. Because when you are calm and just looking at like the lexicon description of a drug, I'm able to read all the indication. But when time is pressing and you're like, come on, find this in 5 seconds and don't screw it up, this becomes overwhelming. And then like a nurse come and show you an EKG of another patient and you're like, like time out, guys. We need to focus. Like, what's the dose? How do we deliver? And move to the next step.
all right.
Yeah.
Well, you started with Apollo 13, and now you're dealing with the Canadian Space Agency.
Yeah, you really did make it now, right? I mean, this is
So-
it. This is what you wanted the whole time.
So you,
Yeah, it
so
was
you
not
were,
some part of
you-
a grand plan. Let's do emergency medicine and mid-career, just scrap emergency medicine and turn into space.
Yeah. So I guess So you applied as one of several people on the application, or
Yeah, what was a bit weird is, in fact, like I had no space ambition at all. Like I didn't even know that it could be relevant to space medicine. But one of our user is a pediatric pharmacist working at the CHIO in Ottawa, and she's a space geek, total space geek. And she actually sent us an email like, guys, it's the Deep Space Healthcare Challenge. You should look into that. But we were like 2 months past the first kind of initial presentation of the challenge. There was 2 weeks left before, and it was a major challenge all across Canada, like hundreds and hundreds of companies. And like, yeah, we're a small nonprofit. But then I look at the video of David Saint Jacques, and David Saint Jacques, like in Canada, especially like in Quebec, like it's a super famous astronaut. And like just having him describe the challenge of space, I was like, okay, let's just imagine we're going to Mars, and like the crew medical guy just starts seizing, okay, like in microgravity, okay, and then you are 4 astronaut with basic paramedic training with the 20-minute delay with Earth, and sometimes during a storm you can be 2 weeks in total autonomy, and you need to kind of find the dose of midazolam and know how to administer it. This is crazy chaotic. And I was like, oh, this is exactly what I do in the emergency. So at that point I was like, okay, maybe we have a chance in this big like Deep Space Healthcare Challenge.
so you won.
Yeah. In fact, it was a long process. And during the course of the process, I took a sabbatical. And then when I tried to come back, and during the sabbatical, we've done easy recess. And at the end of my sabbatical, I started back in emergency medicine. I was super psyched to kind of see patient again, go in recess. But I quickly realized that like it was my feeling was that I had the tree in my house that I nurture like for a year, and after that I was like, oh, there's no way I can get this out right now. It's like taking all the place, so it was almost impossible. I was trying to do my shifts, and my developer were calling me, and so it became like quickly apparent that it was tough to do both at the same time. And we were in the final of the challenge, and at that time I had the idea of doing a space prototype, because like in all the challenge, the goal was to make a solution that could benefit Earth and space, but not necessarily to do both. So to do the space prototype, I decided to pause my career as an emergency physician, went all in on the space prototype, and then we won the challenge past November.
Well, congratulations.
Thank you.
So, do you get to go to a Cape Canaveral or a Johnson Space Center? And
maybe the Canada equivalent, which is the Canadian Space Agency headquarters. And what was really, really like cool is that we got the chance to actually test our space prototype in a parabolic flight. Those kind of a commercial airplanes that go very high. and then
The
it
vomit
simulates
rocket.
micro, exactly, the vomit comet, and it was I was not part of the crew, but I got like the picture of the app floating in space. Like it's really really nice just to think like we built a space prototype that maybe is going to be used on the ISS. Like this is crazy exciting.
Yeah,
That's
I think I
pretty
saw that
amazing.
on the link on your LinkedIn was some video of that. Is that right?
Yep, exactly.
Wow, that's crazy. That's cool. I had not thought about that, but I assume there's applications in multiple worlds. Space, military, where you've got people that are trained in the basics, paramedic level or higher, but maybe they're not used to using certain medications that are really indicated in those settings. And how do
For
you
sure.
sift through that information so that you're just getting just what you need in that moment?
And I find that like the parallel is really interesting. I don't know your perspective, but as an emergency doc, I think that a lot of the time we are selling ourselves short because when you think about it, each time that you're performing something, there's someone in the hospital better than you at doing it. Like let's say that I do a lumbar puncture. Well, the pediatric neurologist is way better than me. I intubate. Well, the anesthesiologist is pretty good at intubating too. But we're good at everything. But it comes to a point where in some institution they kind of see the emergency as, oh, they're taking care of the chaotic part of medicine, but like we are the big brains of the institution. But you think that space exploration is probably like the pinnacle of technology and cool advanced stuff, and to think that the expertise that we have like as black belt and chaos management in the emergency is super useful to them. Like this is a really interesting parallel to be drawn.
Yeah, absolutely.
That's pretty amazing. So, so how many active users do you now have with Easy Resus?
Right now we have 6,000 user, and a portion of that we have like a humanitarian part where we give the app for free. This is like a really big thing that I find so cool. Like we at first, like in 2016, we received a couple of emails like from people from Yemen, and they were like, "It's only like 12 to $12 for you guys, but this is more than I make in a year." And I was like, oh boy, no. Our business model does not involve trying to make money with you guys. Like, give the app for free to everyone, because like we're here for the cause. We want to have an impact with this. So along the years, there's a subset of the of our user base that are using the app for free, and we sell the app to institution. We even customize the content because sometimes, as you were saying, Joel, let's say that you are a paramedic company and in the helicopter you've got like a finite amount of equipment pieces. If you've got a custom version of the app, like it's super useful because then you don't have to scroll past drugs or equipment that you don't need or you don't have it. You have just like the closed list of the material that is available to you.
That's awesome. That's great. Yeah, I'm involved with a nonprofit that does outreach in Guatemala, El Salvador, and a couple locations in Africa. And that would probably be really useful because they do have medical people there, but their training is not to where it is in the U.S. and Canada, that kind of thing. And that would be something really really useful to be able to pass along. So I'll make sure to stay in contact with you on that.
Oh, for sure. And what is amazing is that they, even in the most remote places in the poor countries of the world, they always have access to an Android phone for the most part.
Mm-hmm.
So
Yeah.
this kind of democratization of technology and knowledge is really amazing because before, let's say that we have an MRI that we want to send to Yemen, this is super complex, and then there's the maintenance and the transport and all that. But that this only piece of software, like I'm just going after we end this, a promo code, and then you just distribute the promo code, and then they have access for free, and they can actually have an impact in their practice. I find this like amazing, this leverage of technology to have an impact.
Yeah. That's great.
That's fantastic. So what's the future for Easy Resus?
Oh, there's so much cool stuff to do, Eric. Like right now, what we're working on for the next year, and I'm going to say this live so that I'm accountable in 1 year to actually release this because I'm not even sure that it's feasible. but we're working with our medical illustrator to illustrate every single emergency procedures known to emergency medicine. And what
Wow.
I want is to be able to dynamically generate just what you need. Because, like, let's say that you want to put like intraosseous access to an adult patient. Well, we do this all the time, so not such a big deal. But let's say it's a neonate. Then there's all what's the needle size. I want to be sure that I don't put this into the growth plate. And I find that right now you can go on YouTube and see 20 minutes video or even 5 minutes, but it's not what I need. I'm an experienced emergency practitioner. I don't need to review the whole technique. There is just a couple of key points that I want to see to reassure myself, like what's the dose of lidocaine so that the kid doesn't scream. And I want to be 100% sure. And I want ultimately to dynamically generate all the steps of the procedure specifically for the patient so that you don't need to think about anything else. So you just open the app, you've entered like premature neonate. I want to put an umbilical catheter. You've got the size, you've got all the steps. Boom, 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 you do the procedure. Because I feel that in the bottom of our heart and head, we know those things, but we need kind of this quick refresher just to do it more confidently. So that's the big thing we're working on for the next year. But when you start looking at this, there is so many things to consider and so many literature reviews. So that's a pretty big challenge.
Yeah, I've always thought that for me, emergency medicine, my ideal textbook is just bullet points. Like, like don't give me all
Yeah.
the like. I want those fast, immediate things that I need right now, and then
Yep.
I can read all the other stuff later. But
Well,
Yes, for sure.
that's like, on YouTube, you're exactly right. You can get on there and see about any medical procedure, but the problem is half of them are from the guys that are trying to sell you something, or they're they have something, and other ones are like, and again, you're sifting through information. But I think the beauty of your app is it's just like, this is what you need to know with what you're doing right now, and that'll get you through.
For sure. And the other thing that is super exciting to me, and I don't think that we would be able to do it without like this our space R&D program. So with the space R&D program, what we want to do is to build a vocal interface. Because when you're a paramedic and you're stuck like in an helicopter with a dying patient, to actually like take your phone, like you are already hands-on. So for me, just to be able to talk to the thing would be amazing. And I know that the technology is getting there, but there's a big difference between like talking for fun with ChatGPT on your phone versus like, no, this is the real thing. No time to screw around. And like, so it's kind of a big transition. Like the prototype is super easy, but to do a thing that you can actually trust and use in real life situation is a big challenge, but super exciting.
So here's something that I had always imagined was an app that helped you in a code as well, so that it did all the timers. It's like your last dose of epi was 3 minutes ago. Consider redosing epi or atropine, like where it had those algorithms, and it would just either display it on a big screen so you could see it, or do some kind of auditory call out.
Oh yeah. That's so interesting because then when you think about it, it goes back to the logistics. Like when you're running a code, this is the things where it can go wrong, like those small details, or like trying to find the right algorithm and make sure that DFP is right on time and all that. So by
Right.
giving more love to logistics, I'm pretty sure we'll be able to improve outcomes.
Well, and time warps when you're in a code, right?
Yeah.
Your ability to estimate how much time has passed is very distorted.
Yeah,
Well,
and it's
it is. It's funny because we're all kind of working down our own algorithm, right, at the time in our minds, but yet there's no, it's nowhere to be. It's like in space, so it's like we're all working down this algorithm. I've seen codes where the physician's working down their idea, but the nurse is like, that's not on the normal algorithm. Like, what are you doing? You're deviating from normal care, and it creates this kind of friction. Whereas if you had like something that was like kind of more standardized, they'd be like, oh, I see what you're going with.
Yeah.
Those arguments during codes are never a good thing.
But when you think about it, like, whoops, when you think about it, like emergency medicine is pretty crazy. Just like at each shift that you do, you can see any clinical manifestation of any disease in the entire spectrum of humanity. At the end of the day, this is it. I don't care that you're working in a adult cardiac center. Each 15 years, you'll get a kid that get like hit by a truck, and he comes, and who's going to have to take charge of the kid? Not the ICU. They'll say, oh, it's an adult ICU. Sorry, guys. It's always the emergency folks working like down there. And well, all those algorithms and the bullet points you were talking about, Eric, like I feel that probably that we need to condense all the bullet points of all the textbook of all the specialties out there, so everything, like all the important stuff that the ortho need to know, like it goes in our alley. So at the end of the day, like it's a pretty wide spectrum of things that you need to do.
All right, so that's pretty amazing. So emergency medicine Canada, like I don't have a lot of experience of emergency medicine outside of the United States, although I did, kind of like Joel, I did a little bit of some medical mission work, outreach in Africa. But from your perspective, what are the parallels between Canada and the U.S., and what are the significant differences?
There is so much things to talk about. Like from a clinical guidelines perspective, it's 99% the same. Like I see this a lot because our user base is in the US and Canada, and like in 50 countries, and Canada and US are very, very similar. Oddly, there is some very like weird difference in the drug accessibility, and right now the reason is not quite clear. Like you guys don't have a salbutamol IV or isoproterenol IV, something that we use a lot, but nicardipine, like for us it's super new, but you've been using this for years. So like it's kind of a complex like drug accessibility program. So there's almost the same but slight differences. And for many, many, many years at the beginning of my career, a big difference was anything related to a gunshot wound. Like honestly, at the beginning of my career, the only way that you would have to deal with a gunshot wound would be a hunting accident, or like the cop shot a robber. But there was like really nothing. So for us, each time that it happened, and we were talking to some of our folks in the US, they were like, what? Like we see this like 10 times during our shift. So that was it. And unfortunately, like over the years, like it's become more and more prevalent. But the big difference, and I would really like to hear you guys about this because I never had the chance to ask, but for sure we are a public system. And it's something that honestly I'm really, really proud as a Canadian. And I'm not sure that it's something that is scalable, that is going to work in the long run. Like I'm not a politic guy at all. But one thing that I find super cool is, let's say like there's two parallel universe, okay? My friend is an emergency doc, present in DED, in severe septic shock in ARDS, and he needs to be put on ECMO. And there is a guy, homeless, no paper, no identity, no whatever, in the same condition. During like the stay, there will be absolutely no difference. Like in nowhere along the way, someone is going to say, oh, is there like the insurance are going to cover something as like expensive as ECMO. Like this is not a thing at all. But I just wonder, like, is it like that in the US as well? Like, do you have the opportunity to have extremely advanced care even if you have absolutely no insurance?
I think yes and no, right? So the US is a complicated system because we have some that's, a social welfare system. Although, like you said, what's the long-term, financial viability is always tricky. But if they come through the emergency department and they need ECMO, so you basically they'll get full treatment regardless of the ability to pay. You're not even supposed to ask any questions about insurance until they're completely stable and everything else. So they would get. So the difference, I think, in that scenario, if two people came in the ED at the same time, both with ARDS, both needing ECMO, both going in the ICU, they would both get that pathway. The big difference is, one would have a gigantic bill that they'd never be able to pay, and one would have, some insurance coverage. So I think for my limited, and some people could speak to this much better than I, but I think the bigger difference would be primary care access.
Okay.
Yeah.
So, and again, some of the challenges with the benefit of kind of an open society, there's trade-offs in a lot of different things. So, but in Canada, going to see your primary is no big deal. In the United States, if you have no financial resources and no insurance, you're homeless, your primary care is the emergency department.
Mhm.
Unfortunately, like in Quebec, like uh, emergency department become the primary care doctor of a lot of folks just by they're unable to access. So like there's clearly no perfect system. But I'm really happy to hear that, like, let's say someone is dying in the emergency with no insurance, that the level of care is the same. This is quite cool, actually. I thought that there was along the way, let's say that right off the bat they're not dying, but you intubated them, that the discussion would take place at some point, like we could go to ECMO but you don't have the insurance. But you're telling me that if they are sick, it's like kind of a different pathway, right?
Yeah. Again, once you get into I think your entry into the system through the ED has some protections. So years ago, there was some laws passed, EMTALA, which is like, you must see and stabilize all patients regardless of their ability to pay.
Mhm.
Which I think was a good thing to have done. There's always unintended consequences with any legislation, but uh, that took pressure away from hospital administrators leaning on physicians to make decisions that were not always in the best interest
Mm-hmm.
of the patient, right? So this would be like, hey, they come in the ED, we see them all, we treat them all. It doesn't matter,
Mhm.
you know. Um, and again, I don't have to. I'm just a low level guy. I don't have to deal with the complex macroeconomics of the division and all the other
It's so
issues.
easy to talk, but like so complex and intricate and non-scalable and not economically viable. Like those
Yeah.
are huge topic. But I bet that another thing that is different. I think that the medical legal standpoint in Canada
Mhm.
is quite different, and for sure we go like to ASEP conferences, and we are kind of raised as emergency physician in the same like spirit. All the great teachers that I know are from like the US sphere, and they kind of pass this medical legal way of practicing medicine a bit in our training. I think,
Mhm.
but I think there's a difference there, like that
Yeah.
we the risk is clearly not like dealt in the same way.
Well, and then it's even more complicated in the United States because it differs by state,
Okay.
right? If you want to practice in New Mexico, be ready to get destroyed in a legal case. If you're practicing in Texas, then there's a lot more protection. So, uh,
Yeah, I remember going to a conference. I think it was ASAP when I was in residency, and they were presenting a new. At that time, it was new uh, concept there about AFib. So new onset AFib, short duration, and they were talking about they would just cardiovert them there and send them home, on aspirin or whatever.
Mhm.
And I was sitting in this conference. There was, a few, 500 people, and we were all just like, "Is this guy for real?" Like, And at one point he stopped and he goes, "Now I do understand that in America you could get sued, so it's a little different, but it was interesting because the data they presented was enough to say this was the standard of care. But it was funny because that was the first time I thought like, oh, there's some real differences that affect patient care. And it's funny because there's been a few times where I've had people that have come in, whether and maybe they've had AFib before or whatever, and they say, "Hey doc, just shock me and let me go home. Like I don't want to get admitted. I don't want to sit in the hospital for 3 days, wait for a cardiology consult on Monday because it's the weekend or whatever. Just shock me and get me out of here." And but I think there are some differences like that where, the Ottawa rules of different things and, these kind of things that you can do that in a different medical legal environment. But what it does is I think it gives basis for in the U.S. for us to say, no, these are reasonable treatments. There's no reason that we can't do it this way. You
Yeah.
know.
Well,
It, it
one
it's
thing I would like to get the U.S. to change from a medical standpoint is be more like Europe, where all these stupid MPO restrictions from anesthesia, like,
Yeah.
make those go away.
what I find super interesting, when we put the app on the App Store, at first, like I really thought it was something that could be used, okay, in Canada, maybe in the US, but right now the app is in more than 50 countries. And when you get the chance to talk to those guys, we're kind of all doing the same thing. And when you look like at all the brand name of the drugs are different, but you see like the generic name and yeah, okay, it's the same molecules. So like the differences are less than I thought. Like we have a like Estonian power base user, but I was like in Estonia, like do you treat? But at the end of the day, like they treat other human beings with human beings physiology with the same kind of drug that exists in the entire world ecosystem. So it's funny to think that sometimes it seemed really far, but at the end of the day, like this AFib patient that you're describing, like we all see them everywhere around the world. Like it's
Yeah.
crazy to think about that.
That's awesome. Yeah. Well, Frederic, I'm excited that you got to join. It was a lot of fun talking to you. You've got a lot of energy.
Yeah.
You know, I like your app.
Thank you
Yeah.
so
I
much.
like things that make my
Your
life easier.
app is great, and I'm excited to see where it goes from here. And I really do think it's a wonderful tool. So I mean, I know this is, it's funny when you look at apps, you think, oh, some guy created this over the last 3 months or 6 months, but it's like years in the making. But from ER doctors in the pit on the front line, thank you for doing this. It's a
Thank you
real
so
tool.
much. And guys, I'll be up to my challenge, and I send you an email of all the procedural stuff that we'll figure out next year. So, like, we're going to get back to work.
Fantastic. We'll have to
Awesome.
we'll do a refresher when you come out with the new stuff.
All right.
And
Thank
if
you
you go
so
to
much for having
space,
me.
Yeah, yeah.
send us a picture.
Oh, for sure.
So, all right. Thank you so much. We really appreciate your time today.
Yeah.
Thank you,
Thank
guys.
you.
Thanks.
All right. Bye.